Good afternoon, everyone. Welcome to a special edition of our Grand Rounds today. It is my pleasure to introduce Dr. Fatima Ahmed, who is our speaker today on hyperaldosteronism, etiology, and pathophysiology. Dr. Ahmed received her MBBS degree, which is a MD equivalent at University of Khartoum in Sudan. She then completed her residency in internal medicine at Advocate Illinois Masonic Medical Center, followed by endocrinology fellowship at Wayne State University. She's currently working as locum tenens and hoping that she would join MCW. And she's interested in cardiovascular endocrinology, hypertension, diabetes, and obesity. Welcome, Fatima.
Hi, everyone, and thank you so much for having me in today. So I'm going to talk about hyperaldosteronism, etiology, and pathophysiology, with some focus also on primary aldosteronism. So I have no financial disclosure to this presentation. The objectives is mainly the classification of hyperaldosteronism, etiology, the pathophysiology, and the clinical features of primary hyperaldosteronism, an interesting case that I saw, and some conditions that mimic aldosterone excess. So hyperaldosteronism, generally, hyperaldosteronism is classified into two major types, primary and secondary. And the primary hyperaldosteronism is usually renin independent. So there is something in the adrenal gland that leads to secretion of aldosterone, and then the aldosterone will actually suppress the renin. So it's renin independent. While secondary hyperaldosteronism is renin dependent. That means the renin is the driving factor for high aldosterone. So hyperaldosteronism can either be primary or secondary renin independent or renin dependent. So primary hyperaldosteronism was described by Dr. Jerome Cohn in 1954, and it was named Cohn syndrome after him. And primary hyperaldosteronism is further divided into sporadic and familial. And by sporadic, we mean that genetic changes are usually acquired during the lifetime of the individual, while a familial pathology is a genetic that has been inherited from someone's parent. So again, hyperaldosteronism, primary and secondary, and then the primary is further subdivided into sporadic and familial. So for sporadic hyperaldosteronism, 60 to 70% are usually caused by bilateral idiopathic hyperaldosteronism, which is also termed an idiopathic hyperplasia, unknown etiology. And then 30 to 40% is caused by a unilateral aldosterone-producing adenoma. And less than 30% is caused by a micro or macro nodular hyperplasia, usually unilateral, and then the others are caused by tumors. So those tumors can either be an adrenocortical carcinoma that is purely secreting aldosterone, or it can be an ectopic aldosterone secreting tumor from neoplasms in the ovary or the kidney. And as I mentioned, the primary hyperaldosteronism can either be sporadic or familial. And in familial hyperaldosteronism, there are certain pathogenetic variants. They are classified into types, type 1, 2, 4, the PASNA, and type 3. So type 1, it's mainly due to a pathogenetic variant in the CYP11 beta 1 that makes 11 beta hydroxylase, or CYP11 beta 2 that makes aldosterone synthase. Type 2 is due to a mutation in the chloride channel gene, and also the familial occurrence of aldosterone-producing adenoma and bilateral idiopathic hyperplasia, or both. Type 4, the pathogenetic variant, is a calcium voltage-gated channel, subunit alpha 1H. And then the PASNA, which stands for primary aldosteronism, seizures, and neurologic abnormalities. And it's due to a pathogenetic variant in calcium voltage-gated channel, subunit alpha 1D. In 2008, type 3 hyperaldosteronism, familial hyperaldosteronism, was first reported at the Journal of Clinical Endocrinology and Metabolism, and it's due to a mutation in potassium channel subfamily J, member 5. This was peculiar that there was also autonomous cortisol production that is not suppressed by dexamethasone, and causing severe hypertension in early childhood that is very resistant to aggressive antihypertensive therapy and requires bilateral adrenalectomy. So hyperaldosteronism is a primary and secondary. We talked about the primary hyperaldosteronism etiology, and then secondary hyperaldosteronism is due to a pathology not in the adrenal gland. So something that happens that leads to high renin. It can be a reduced renal blood flow due to atherosclerotic renal disease, renal vasoconstriction, or an edematous disorder like heart failure, cirrhosis, or nephrotic syndrome, or a renin-producing tumor, which are termed reninoma. Those are benign tumors originating from the cells of the glomerular apparatus, or pregnancy. And I found that interesting that pregnancy actually leads to hyperaldosteronism because the placenta secrete renin. And also the estrogen, all this in pregnancy because the high volume is needed to accommodate the fetal growth. And this will lead to increase in the deoxycorticosterone and aldosterone. So the renin-angiotensin-aldosterone system starts with when the kidney signals that there is low blood pressure. This is the normal physiology. Low blood pressure, the kidney will sense that. The kidney will secrete renin. Renin will convert angiotensinogen to angiotensin 1. And angiotensin 1 with angiotensin converting enzyme will be converted to angiotensin 2. Then angiotensin 2 can act directly on the blood vessels and leading to vasoconstriction, where it causes hypertension. Or angiotensin 2 also can act on the adrenal gland. And remember, adrenal gland has an adrenal cortex and medulla. And the adrenal cortex further has 3 layers: the zona glomerulosa, zona reticularis, and zona fasciculata. So angiotensin 2 specifically will, when it acts on the zona glomerulosa of the adrenal gland, this will lead to secretion of aldosterone, and aldosterone is going to act on the kidney. We'll explain that in a second. How does it specifically act, leading to salt retention and hypertension? So what are the renal actions of aldosterone? So just a quick reminder, the kidney anatomy, there is a renal capsule, then the proximal convoluted tubule, the loop of Henle with the descending, ascending, and then the distal convoluted tubule and the collecting ducts. So in the collecting ducts here, the cortical collecting tubule, the principal cells, this is the major site of the action of aldosterone. And that's where the aldosterone act and increase the sodium channels. And when there is increase in the sodium channels, so this diagram here shows more like zoomed in view of the principal cells. The sodium channels will lead, when they are more, there will be more absorption of sodium. So the tubular lumen is going to be more electronegative. And then the principal cells are going to secrete potassium. So the end result is that there will be sodium, increase in the sodium reabsorption and increase in the potassium secretion. So after a while, there is an aldosterone escape phenomenon that happens. So the body will sense that there is more sodium and water retention. This will be followed by spontaneous diuresis. So what is the mechanism behind this? Actually, there have been many postulated mechanisms for this. One of them is that when the body senses that there is high hypervolemia, this will lead to secretion of atrial natriuretic peptide. The second postulated mechanism is that Remember the kidney again, the renal capsule, proximal convoluted tubule, the loop of Henle, distal convoluted tubule, and the collecting duct. And we talked that here in the collecting duct, there was the principal cells where the aldosterone act to increase the absorption of sodium through increasing the sodium channels. So in the distal convoluted tubule, here there is another channel that is called thiazide-sensitive sodium chloride cotransporter. So this thiazide-sensitive sodium chloride cotransporter will be decreased. There will be decreased abundance of these channels, and so the sodium reabsorption will decrease. A third postulated mechanism is that just by hypervolemia, this will lead to pressure natriuresis. So this is regarding the sodium and water retention. So how about the potassium secretion? There is potassium secretion, there is hypokalemia. Is this going to continue forever, or what is going to happen? So usually when there is hypokalemia, the body also like counterbalance this. There will be some potassium returning effect. It's not going to lose all the potassium. And it was found that the potassium will stabilize at a lower level. So progressive hypokalemia is not expected to occur with primary hyperaldosteronism unless another factor is added. Example, if the patient is on diuretic therapy. So the end result of the renal actions of aldosterone is that there will be a new steady state, stable level of increased extracellular fluid volume, decreased plasma potassium concentration, and they are at a stable level. If we measure the urinary sodium and potassium, the urinary potassium, they should be roughly equal to dietary intake. One of the features of hyperaldosteronism is metabolic alkalosis. So where does this come from? There are two mechanisms. So in the intercalated cells of the cortical collected tubules, there are two pumps. The first pump is called the hydrogen ATPase pump. So this hydrogen ATPase pump, when there is hypokalemia, it will secrete hydrogen ion, leading to metabolic alkalosis. And then the second pump is the the first pump is the hydrogen potassium ATPase pump. This is the pump. When there's hypokalemia, there will be secretion of hydrogen ion leading to metabolic alkalosis. And then the second pump is the hydrogen ATPase pump. And this one directly is stimulated by aldosterone, also leading to secretion of hydrogen ion, leading to metabolic alkalosis. So what is the pathophysiology of aldosterone-producing adenomas? 90% of cases, they are called by somatic mutations that causes aldosterone hypersecretion. However, it was found that identification of those mutations doesn't really affect the management. So what are those mutations? This diagram is showing the glomerulosa cell of the adrenal gland. And the glomerulosa cells are the ones that secrete aldosterone. So there is a channel here called the potassium chloride channel 5. This is the one that is usually mutated in 40% of cases of aldosterone-producing adenomas. So when these channels are mutated, there will be increased sodium conductance, and then calcium will enter into the glomerulosa cell. This will lead to cell depolarization, and the end result will be aldosterone production. So in 40% of cases of aldosterone-producing adenomas is due to a mutation in the potassium channel J5. Other mutations have been described in voltage-gated calcium channels, sodium-potassium ATPase alpha subunit, the calcium ATPase, and beta-carotene, but they're less common compared to the potassium channel. Idiopathic hyperplasia. Idiopathic hyperplasia is another cause of primary hyperaldosteronism, and it's usually bilateral. Occasionally, it's unilateral. Till now, the pathophysiology is not completely understood. A postulated mechanism is that angiotensin II adrenal hypersensitivity. However, when these patients, they were given angiotensin 2 inhibitors, it wasn't reversed. So we still need more research. We need more genetic studies to identify the etiology of idiopathic hyperplasia. So the clinical features of primary hyperaldosteronism, the first clinical feature is hypertension. So there is volume expansion, the volume expansion acting on blood vessels, leading to increase in the systemic vascular resistance. So what is the question that I had in my mind is, what is the mean blood pressure for patients with primary aldosteronism? So this study was published in Annals of Internal Medicine, was a retrospective analysis of 82 patients. Was found that as the results of the study found that patients with adrenal adenoma, the mean blood pressure was 184 over 112. And patients who had adrenal hyperplasia, the mean blood pressure was 161 over 105. And then the second question I had is primary aldosteronism associated with resistant hypertension? Resistant hypertension defined as failure to achieve blood pressure, the goal blood pressure, despite adherence to 3 medications, including a diuretic. So this study was published in Lancet about the prevalence of primary hyperaldosteronism in resistant hypertension, was also a retrospective analysis of 1,616 patients with resistant hypertension. 11% of those patients, they fulfilled criteria for primary aldosteronism. And then can some patients who have serum aldosterone level in the high normal range, can they have high blood pressure? That's another question that I had. So this study was published in the New England Journal of Medicine, and they collected the baseline serum aldosterone in 1,688 non-hypertensive patients. So at baseline, they were non-hypertensive. And then they followed those patients for 4 years. And then after 4 years, there was increase in blood pressure in 34%, and 15% of those patients had hypertension. So then they looked at the serum aldosterone and compared the serum aldosterone at the lowest quartile, which is 2 to 7 nanogram per deciliter, comparing them to patients who had serum aldosterone in the highest quartile, 14 to 60 nanogram per liter. So the odd ratio for those patients, so they were like 1.6 more to develop hypertension and 1.6 more to have increase in blood pressure. However, this study had some limitations because the level of serum aldosterone did require the knowledge of the exact level of salt and potassium intake and plasma renin value. This was not available in this study. So regarding hypokalemia, historically, hypokalemia was a major feature of primary aldosteronism. It was a major clinical feature. However, nowadays, only 9 to 37% of patients, they do have hypokalemia, who have, or like reported 9 to 37. Some studies reported different numbers. I'll explain that in a second. However, why is that? Because mainly more patients, look like there are more patients who have hypertension are now being screened for hyperaldosteronism before they develop the hypokalemia. That was a possible reason for that. So this study published in the Journal of Clinical Endocrinology and Metabolism, and it was done in 5 centers from 5 continents, retrospective analysis, and the data showed that less than 50% of patients diagnosed with primary aldosteronism were hypokalemic at presentation. So hyperaldosteronism is associated with a cardiovascular risk, and this has been known, like even compared to patients who have other types of hypertension and they are age, sex, and blood pressure matched, but they have hyperaldosteronism, they were found to have higher cardiovascular risks. So what are those risks specifically? It's greater left ventricular mass and a decreased left ventricular function. Other cardiovascular risks include stroke, myocardial infarction, and atrial fibrillation. So hyperaldosteronism is also associated with a metabolic risk. It was found that they have higher prevalence of type 2 diabetes and metabolic syndrome. And this might explain the increased cardiovascular disease morbidity and mortality in these patients. Regarding the renal effects and the renal risk, it was found that hyperaldosteronism increased the GFR renal perfusion pressure, independent of systemic hypertension, and also leads to urinary albumin excretion. So this has been found to be reversible with treatment. So in this study, published in JAMA in 2006 about the long-term renal outcomes in patients with primary aldosteronism. It compared two groups, patients with primary aldosteronism treated with adrenalectomy or spironolactone, compared to patients with primary hypertension started on antihypertensive therapy. So at baseline, patients who had primary aldosteronism compared to the second group, they had a higher GFR and higher albumin excretion. And then the patients were followed for 6 months, and the patients who had primary aldosteronism who were treated with either adrenalectomy or spironolactone, they had higher reduction of GFR and higher reduction in albumin excretion. So hyperaldosteronism can be associated with muscle weakness, mainly due to hypokalemia, and it is more notable if the potassium is less than 2.5. And then hyperaldosteronism, aldosterone leads to sodium retention. So it does have a mild hypernatremia. The patients will have sodium levels between 143 and 147. Actually, it's mild hypernatremia because the body will also sense that there is mild volume expansion, so there will be reset of the osmostats that are regulating the ADH and the thirst. Other electrolytes abnormalities that are noted is also hypomagnesemia. So why do patients with hyperaldosteronism have hypomagnesemia? It's usually due to urinary magnesium wasting. It's incompletely understood why, but one of the postulated mechanisms is that the ascending limb of the loop of Henle, which is the primary site for tubular magnesium reabsorption, this tubular magnesium reabsorption, when there is inhibition of the sodium transport during the aldosterone escape phenomena, it might be associated with a parallel decline in magnesium reabsorption. So an interesting case I saw was a patient who was an 82-year-old male, had a past medical history significant for prostate cancer and hypertension, came for follow-up to his primary care doctor because he had hypertension, was diagnosed with hypertensive urgency, transferred immediately to the emergency department. His history of present illness significant for progressive weakness, fatigue, polyuria. He can walk only half a block before getting tired. He drinks 5 to 6 bottles of water daily, typical for him for years, denies any other symptoms. And his review of systems is all negative. Other histories that were significant, he had a history of prostate cancer, hypertension, and the prostate cancer was treated with salvage cryoablation of the prostate. He's a former tobacco smoker. His sister has hypertension and breast cancer. This is a list of his home medications, and we can note that he was on lisinopril, which is an ACE inhibitor, and he was also on a medication called abiraterone, that's used for prostate cancer. So his vital signs were remarkable for hypertension. Systolic blood pressure was 200, diastolic blood pressure was 105. This is an admission, and his physical exam is normal, and his labs were remarkable for hypokalemia. So his potassium has been low in spite of being replaced by potassium, like for many days. The primary team was trying to replace it with potassium, and it didn't correct. And so that the hypertension, he continued to be hypertensive in spite of being on multiple medications, nifedipine, carvedilol, hydralazine, and all this did not correct high blood pressure. His lisinopril was held because they wanted to do some labs and thought that might interfere with the lab results. So they consulted oncology for the metastatic castration-resistant prostate cancer to evaluate the chemotherapy regimen, and endocrinology was consulted for a patient who has hypertension, hypokalemia, and metabolic alkalosis, and the bicarb was 40. So what's the working diagnosis? The working diagnosis is hyperaldosteronism, and in our patients, we did labs, and just before going into the labs, a quickly reminder of the criteria for diagnosing hyperaldosteronism. We'll do plasma aldosterone concentration, the plasma renin activity, or the plasma renin concentration. So if the plasma aldosterone concentration is more than 10 and associated with suppressed renin, plasma renin activity less than 1, the second thing we'll ask if the patient has a spontaneous hypokalemia, and he have also a plasma aldosterone concentration more than 20. If yes, this would diagnose primary aldosteronism, and if no, then the patient would need a confirmatory testing. If the patient doesn't meet those criteria, then aldosterone concentration is less than 10, the renin activity is more than 1, so it's less likely to be a primary aldosteronism. So this patient, his aldosterone level was low. It's less than 1. And then the plasma renin activity was suppressed. And his aldosterone renin ratio was less than 5.6. So does anybody know, like, what could be an explanation for this? Patient has hypertension, hypokalemia, metabolic alkalosis, but his aldosterone level is low and his renin is suppressed. And the aldosterone renin ratio is also not more than 20. So what could be going on in this patient? Mm-hmm. So he is, just a reminder that he's been hypokalemic for a while. He had prostate cancer since 2010, has been hypokalemic. So just being hypokalemic, the potassium is not there.
I don't know if anyone mentioned licorice or licorice-like things or HS1 deficiency.
Yeah, so he doesn't have a history of licorice ingestion. And then what was the second thing you have mentioned? The licorice ingestion is negative. And what was the second thing? I just didn't hear it.
There's a mutation that is what the enzyme, the glutaric acid, inhibits, and I forget what that's called. I forget that mutation.
Sorry, can you repeat the question?
So another possibility is the mutation. I think it's HSD1 or something like that. That looks like licorice because it's the enzyme that glutaric acid inhibits. Maybe I'm off on that. I don't know. Somebody who knows more about this can answer.
Okay, all right, okay. And then just given that he's also hypokalemic for a while, and the hypokalemia is not really been corrected. So whether this aldosterone level is truly low or no, because usually hypokalemia would suppress the secretion of aldosterone. It's a possibility, but it's not still like doesn't explain the situation completely. And then patient who he's on lisinopril, he's an ACE inhibitor. So if somebody's on an ACE inhibitor and still have a suppressed renin, this might also signify that there is something else going on. So aldosterone is high. So because ACE inhibitor would decrease the conversion of angiotensin to angiotensin 2 to angiotensin 1, and then should lower the aldosterone a little bit, and then the renin we should expect it to be a little bit high, but it is still suppressed. So this patient does have a kind of hyperaldosteronism going on. However, still, those were just like postulated mechanisms. And as you mentioned, the licorice, he wasn't taking it, but then what could else be going on? So what other conditions that mimic aldosterone excess? So is it congenital adrenal hyperplasia? And in congenital adrenal hyperplasia, the enzymes that could be blocked, is it 11 beta hydroxylase deficiency? Is it 17 alpha hydroxylase deficiency? Because blockage or deficiency in those enzymes would lead to accumulation of the aldosterone precursors, the oxycorticosterone and the corticosterone. However, this patient is 82 years old, so less likely. Is it licorice ingestion? So what does licorice do? So it's the active ingredient is glyceric acid, and this would inhibit the enzyme 11 beta hydroxysteroid dehydrogenase type 2. And this enzyme is responsible for the conversion of cortisol to corticosterone. So we don't have a lot of cortisol to act on the mineralocorticoid receptor. So when this enzyme is deficient, then there will be a lot of cortisol, and it can act on the mineralocorticoid receptors, and this will lead to a condition of hyperaldosteronism. So another medication that is carbinoxolone. So this medication also is a derivative of glyceric acid, and it's used for the treatment of oral, esophageal, and peptic ulcers. So our patient, still, he didn't meet any of the previous criteria, and he have hypertension, hypokalemia, labs consistent with hypoaldosteronism. So what else could be going on in this patient? Any thoughts?
Well, this is due to the, can you hear me?
Yeah.
This is Dr. Finley. Yeah, I mean, this is obviously due to the abiraterone, which is a inhibitor of 17 alpha hydroxylase. So they have, high DOAC levels. So his 11-deoxycorticosterone level will be very high. It's ACTH driven 11-deoxycorticosterone. So the treatment is either dexamethasone or prednisone.
Mm-hmm. Yep.
That makes complete sense because the 17-hydroxylase deficiency is congenital adrenal hyperplasia, causes hypertension and lack of sex steroids. Am I correct?
Yes.
Okay, so it makes sense that a medicine for prostate cancer would do that. I didn't know that, but thank you.
Yeah.
Thanks, Jay.
So thank you very much. So patient, just to mention that our patient imaging showed normal adrenal gland, and going to the oncology history, doing more detail. So this patient in 2012, he was starting on this medication, abiraterone, and he was started on prednisone. And then in the same year, that's when he started to develop this resistant hypertension and hypokalemia. Right? So the culprit is this medication, which is Zytiga. This is the name, and then abiraterone acetate is the generic. So this medication is used for metastatic prostate cancer resistant to androgen deprivation therapy, that is resistant to castration, and they still, it's postulated that because those patients, they have androgen production from the adrenals and prostate, so we need something to block these androgens. So the mechanism of action of abiraterone acetate is that it blocks the biosynthesis of androgen through inhibition of cytochrome P450C17, so cytochrome 17A1, and this makes two enzymes, the 17-alpha hydroxylase and the 1720 lyase. So when there is inhibition of those two enzymes, we will expect that the mineralocorticoid precursors, the deoxycorticosterone and the corticosterone, would be elevated. Okay. However, because the same medications, they block this medication because it blocks 17-alpha, and what do we expect the cortisol to be in this patient? Any thoughts? Yes, so if the cortisol is low, what's going to happen to the ACTH? It's going to be high. So if the ACTH is high, this is going to increase more of the mineralocorticoid pathway here. So the deoxycortisone is going to increase, and the corticosterone is going to increase more. All right, so so the patient, when in this specific patient, when we measured the cortisol, it was 2.6, so it's low. The ACTH level was 93.4, and as we said that because the cortisol would be low, and this will lead to high ACTH. So how are we going to treat this? So I think somebody just mentioned giving prednisone. So what do we do when we give prednisone to this patient? How is it going to lower? Because it's going to suppress the ACTH. Okay, so if we give prednisone, it's going to suppress the ACTH, and this will decrease the mineralocorticoid level as well as replacing the cortisol. So the question is, how much glucocorticoid are we going to give this patient? This is a question that I had, and then looking up to this study published in the Oncologist Journal. It was a retrospective study of 15 patients who had castration-resistant prostate cancer. Then in those patients, they were already on abiraterone acetate 1 gram per day. They gave those patients daily prednisolone, 10 milligram per day, and then they measured the concentration of the prednisolone. So in this graph here, this is the concentration of prednisolone. The median concentration was 152. And doing the conversion of prednisolone to hydrocortisone, it's 4:1, and this is in the physiological range. So it was recommended like a dose of prednisolone. Prednisone is equivalent also to prednisolone, so a dose of 10 milligram per day could be a good idea for this patient. Also in the same study, if you look at this graph, the y-axis represents the ACTH level, and then in the x-axis represent 3 groups of patients. So the first group is a group of patients who were not started on abiraterone, and their ACTH level was 17. And then the same patients, when they were started on abiraterone, their ACTH increased 6 times. From 17, it went to 124. And then the same group of patients, when they were started on dexamethasone, and the dose, it was 0.5 milligram per day for 14 days only. The dexamethasone did suppress the ACTH, and it went to very low level. So it was below the limit of sensitivity. So oncology team was, we discussed with them, Zytiga was held, and then for the hypertension, we added spironolactone, started with a 25, and then increase it to 50. Still, the hypertension, hypokalemia didn't resolve. We continued lisinopril, nifedipine, and then started the patient on prednisone 10 milligram oral daily, and mainly to suppress the ACTH. Hypertension was controlled. Then this is the same patient in a follow-up 1 week afterwards. His hypertension was controlled, the hypokalemia resolved, potassium level was 4.6, and then continued again on prednisone 10 milligram oral daily. So for how long are we going to continue the prednisone? This is another question. How long should we hold the prednisone after Zytiga discontinuation? So doing some literature review, there is a case report of a patient reported in September 2014 who had also castrate-resistant prostate cancer, started on prednisone after abiraterone, and then the rationale was exactly the same question: for how long are we going to continue the prednisone? Because there's no available data, it's unclear what's the duration of inhibition of the CYP17A1. So this was a 58-year-old African-American male who had a castrate-resistant prostate cancer and didn't have a history of hypertension. And he was started initially on Zytiga and prednisone for 6 months, and then developed resistant hypertension and hypokalemia. Chemotherapy was discontinued. And then on day 6, after discontinuation of abiraterone and prednisone, he was started on 0.5 milligram dexamethasone daily. And then after that, the blood pressure improved, the hypokalemia improved. So the hypertensive medication, the potassium supplements were able to be discontinued. However, this is the only case report that I found in this. And then in the discussion, it is mentioned that we know for how long will the albuterone be in the system. It's like around 12 hours. So this is the elimination half-life of this medication. There is some time needed to regenerate the functional CYP17A1 enzyme and restore the hypothalamic adrenal axis, but for how long is not really known. So it's recommended that clinicians, they need to consider just steroid therapy, but for how long, we don't know. I would follow up the patient just regularly in the clinic and start to taper the steroid and monitor the blood pressure, monitor the potassium, and probably need more studies in this. So let's remember that Zytiga, abiraterone acetate, is used for metastatic castration-resistant prostate cancer. This can be associated with hyperaldosteronism because it blocks the androgen biosynthesis via inhibition of CYP17A1, 17-hydroxylase, 17-20-lyase. And then those patients would need to be, if they developed hyperaldosteronism, hold the Zytiga and supplement them with prednisone 10 milligram daily. Yeah, and this will bring me to the end of my presentation. Any questions?
Are there any questions? Thank you.
This is Joe. Thank you. That was really interesting and very, very informative. Appreciated it. So, if you're giving a medicine that blocks the synthesis of estrogen too, right? If you're giving a medicine that blocks the synthesis of sex steroids and giving them prednisone, is there any standard of care for the skeleton of are they automatically treated with a bisphosphonate, other than just androgen delp, where it's more nuanced? These patients would seem to be at pretty high risk for bone disease.
Yeah, I think that's a good question. Based on the literature review, the studies, it looks like there's no currently a specific standard of care. So the recommendation is if somebody's on Zytiga and then they had developed this hyperaldosteronism, is to hold it and then start the prednisone and just monitor the patient in the clinic till
Okay.
the blood pressure and the potassium level, and then wait till probably the enzyme would regenerate again, and regenerate the gene would, whether this is reversible or irreversible, still like not completely understood as well.
Okay, so they're not routinely put on prednisone then?
Yes, they are. Yeah, Joe, they're supposed to be routinely placed on prednisone.
Do they all have skeletal metastases?
I don't know the answer to that, but I would guess the majority of them do, yes. I mean, most of these patients,
they're already on antiresorptive therapy then. Okay.
they should be getting reclassed or whatever. Yeah, exactly.
Whatever. Okay, thanks.
From your slide when you were giving the protocol that was used with this patient, it looked like the patient, if I'm remembering correctly, the patient was initially placed on Zytiga and prednisone 5 milligrams twice a day right away, and then developed it. Was he not taking the prednisone, or what happened with that?
Yeah, I think that's a good question, but
and anyhow.
Yeah, he's getting the prednisone.
Right from the start, the way it looks.
Yeah. I'm not. I'm not sure if he wasn't. Probably he was not taking it, because probably if he was taking it, it would have suppressed the ACTH, so he wouldn't, have developed this side effect. But then it's the question, like, if somebody's already on the prednisone, does that still inhibit? There is a question here, like, does it still inhibit that those patients will not develop hypertension and hypokalemia? I think this is also, unless if we do like compare patients on prednisone versus patients on not on prednisone, I think we would not know a clear answer, because at the end of the day, the enzyme is going to be inhibited, and we need to hold the Zytiga for.
It's possible some people need higher doses, because I think you're
So we
kind
did
of
five milligrams. And
twice a day.
the dose that you mentioned may not be applicable to everyone.
Yes, that's possible also. Another explanation, yeah. He was on 5 milligram, and then the dose is 10 milligrams.
What it said on that.
Yeah, in my anecdotal experience, which isn't large, that the patients I've seen with this who are, to control them well, you need at least 5 milligrams of prednisone twice a day at a minimum. And most of the patients I've seen who are well controlled are cushingoid. I mean, they actually are probably getting it. So it's really a fine line between trying to keep these patients from having glucocorticoid excess and enough suppression of ACTH to afford them a normal mineralocorticoid activity and normal potassium and blood pressure. So it's not easy to do this, and it really, I think, I mean, the oncologists who are giving this, they don't understand this at all. I mean, you can imagine this is hard for endocrinologists to understand. You can imagine how hard it is for an oncologist or for the patient to understand it. So it's often overlooked, the steroid replacement therapy. The patients stop it for whatever reason, and then it doesn't get restarted. And what's amazing is that they don't have, clinical adrenal insufficiency, even though the cortisol level is 2.6 or whatever, it's low. And presumably that's because corticosterone levels are very high, and corticosterone is the other glucocorticoid, obviously the prominent one in rodents, but probably may have some effect in humans. So maybe that's why they don't have, of course they have hypertension, but they don't have other signs and symptoms of glucocorticoid deficiency.
And probably that might also tell us that maybe the patient, he was taking the prednisone as well, so he's taking it.
Can they be restarted on it eventually? Like, once this gets resolved, can they be restarted on this med and then you just increase their steroid dose? Or do they have to be off it now?
Yeah, I think that's a good question. I I personally, if the patient developed this side effects for it and resistant hypertension, hypokalemia, I personally would not, but of course I would consult more with oncology to see if they have any other alternative in this case, because maybe there are some patients who are more susceptible compared to other patients who are not. Yeah.
A couple patients that I've seen on consults with this over the years, it's just been like 2 of them, and they were like, last ditch type thing with their prostate cancer, and they were just, this was kind of used as a last ditch effort, and so they're pretty sick.
Yeah.
There's not really much that they can use. Yeah. So it's not used very often because it's just when it gets really bad and nothing else is working.
Yeah, and and I think for this patient specifically, oncology did recommend another medication called doxetil as a chemotherapeutic alternative. However, I think it's a good question to see, is it just Zytiga, or can we have other alternatives in this? Yeah.
And I think that it's not so I haven't had much experience either other than seeing in consults. But if anyone could increase in dose to 20 milligrams of prednisone would have solved this at all? Does anyone have seen?
Well, we went up on the dose on the prednisone because the patient was on, I can't remember exactly what it was, but we did go up on the dose and the patient actually got better, and so that's what we did, and then tried to come down once we got him better controlled, then tried to come down on the dose a little bit. So, but he was like so far.
Yeah, I think it was end stage. I mean,
it was
it's
end stage when you pull out this drug. Yeah. But you try to explain the mechanism and they think you're just a genius because it is. It's like you said, it's difficult for endocrinologists to understand, but for them, they have no idea. Yeah. It's like, well, no, there is a reason for this. Yeah.
I think.
I don't see any other questions in the chat box. Anyone else have questions in the room or in the ether? All right, so thank you very much, Dr. Ahmed. We really enjoyed your talk.
Thank you. Thanks for having me.
Thank you, everyone, for joining.
That's great.
Thank you.
Angela, can we add her to our